Hello everyone and welcome to another video in our high yield series. Now in this video we will be talking about renal tubular acidosis. Renal tubular acidosis. So whenever you see renal tubular acidosis, I want you to think about normal anion gap metabolic acidosis. So this is one of the most important causes for normal anion gap metabolic acidosis. And whenever I say normal anion gap metabolic acidosis, I want you to think about bicarbonate loss. Okay. And bicarbonate loss occurs in two ways. One is through GI loss, the other one is through renal loss. So we are not going to talk about GI loss now. The renal loss, we are going to talk about the renal loss. The main mode by which bicarbonate is lost through the kidney is RTA, renal tubular acidosis. So let's go straight into the topic. There are three types of renal tubular acidosis. Type 1 is distal, type 2 is proximal, there is another one which is type 4. And you can see the nephron and the different parts of the nephron and the areas where the different diuretics happen in the nephron. So let's talk in detail about normal anion gap metabolic acidosis. So normal anion gap metabolic acidosis, you just calculate the anion gap by this formula: total positive charge minus total negative charge. So the total positive charge is represented by sodium and the total negative charge is represented by the sum of chloride and bicarbonate. So what happens when renal tubular acidosis or normal anion gap metabolic acidosis is that, for example, if the sodium concentration is 140 and the bicarbonate is say 10, and the normal anion gap, let me tell you at the beginning, the normal anion gap is between 10 to 12. So this has to come between 10 to 12. So for that, what will happen? The chloride concentration is going to increase. Okay, so if you want to make it, if you want the anion gap to be 10, or in other words normal, you'll have to increase the chloride concentration. So what will the chloride concentration be here? It is 140 minus 130, 120 plus 10. So 140 minus 130 is equal to 10. So the anion gap is normal. So you know that the normal chloride value is between 98 to 108. Okay, so what has happened here is that chloride concentration has increased to compensate for the bicarbonate loss. As I told you before, whenever you think about RT, renal tubular acidosis, you need to think about bicarbonate loss. So bicarbonate is being lost, so to compensate for that, chloride is increasing to maintain the anion gap, to keep the anion gap within normal limits. So that is what is basically happening. Contrast this with increased anion gap metabolic acidosis. Increased anion gap metabolic acidosis is due to increase in unmeasured anions. Increase in unmeasured anions in the body. This could be anything. This could be acetone, acetoacetate, beta-hydroxybutyrate, lactate, could be anything. But the key point to remember is that it is unmeasured. So the anion gap in the case of increased anion gap metabolic acidosis would be something like this. So the sodium will be 140 minus the chloride will be normal in this case. So for example 102, and the bicarbonate, because it is metabolic acidosis, bicarbonate is going to be decreased. So bicarbonate, let's say it's 15. So it is going to be 140 minus 117, which is 23. So you can say that the anion gap is increased. Now this increased anion gap, mathematically you can see an increased anion gap. But what is happening is basically there is increase in the amount of unmeasured anions, which is bringing the bicarbonate down. So for example, if there is lactate, if there are like 15 molecules of lactate, this 15 molecules of lactate will be added to this 117. So what will it be? 117 plus 15, that will be 132. So 132 is within the, so 140 minus 132 will be 8. So it is a kind of normal anion gap. Because there is this tendency to maintain electrical neutrality, whatever anion is increasing in the body, it like takes the place of bicarbonate. Okay, So if the bicarbonate goes down, the unmeasured anion is going to go up. So that is the case with increased anion gap metabolic acidosis. But with normal anion gap metabolic acidosis, there is no increase in any unmeasured anion, as in there is no lactate, there is no like acetone, acetostate, or beta hydroxybutyrate. Basically, it's a bicarbonate loss. So to compensate for the increased loss of bicarbonate, what happens is that the chloride increases. So there will be a state of hyperchloremia in normal anion gap metabolic acidosis. So these are some of the basic concepts that you need to understand. So now let's go straight into the different types of renal tubular acidosis. So type 1 RTA, as I told, is distal renal tubular acidosis. And the main mechanism by which the body gets rid of excess acid is by uh, secretion, H plus secretion in the distal convoluted tubule and the collecting tubule. So in type 1 RTA, there's a problem with the alpha intercalated cell of distal convoluted tubule and collecting tubules. So because of that, there's a dysfunction of the pump which is secreting hydrogen. So as I told before, hydrogen secretion is the main mode by which body handles renal acid. It is responsible for excretion of 80% of renal acid excretion. 80% of renal acid excretion is through H plus secretion in DCT. So if this mechanism is lost, you can like clearly get an idea that the metabolic acidosis is going to be very severe. Okay, and another thing which happens when H plus is secreted is potassium is reabsorbed. So as I told before, there is this tendency to always maintain electrical neutrality. A positive charge is lost, a positive charge is gained. A negative charge is lost, some other negative charge is gained. So H plus is secreted, and along with that potassium is reabsorbed. But since this mechanism is lost in type 1 RTA, H plus is not secreted and potassium is also not reabsorbed. So that tends to occur a severe potassium loss. Just as I told before, the acidosis tends to be severe. Because of severe acidosis, the potassium also tends to be severe. Potassium loss also tends to be severe. So hypokalemia is one characteristic feature which occurs in type 1 or distal RTA. So why does this occur? Because of the defect in the alpha intercalated cell of DCT. It has the hydrogen potassium ATPase pump. Hydrogen is not secreted. So hydrogen is retained in the body. So because of that, there is metabolic acidosis. So because hydrogen is not being secreted, potassium also is not being reclaimed. So potassium is also being wasted in the urine. So there will be severe potassium loss also. The metabolic abnormalities that you can see are severe hypokalemia, hyperchloremia. Why does hyperchloremia occur? Just as I told before, explain the mechanism behind normal anion gap metabolic acidosis. There is a tendency to maintain electrical neutrality because of bicarbonate loss. Chloride is retained to maintain electrical neutrality. Another important thing which occurs is hypercalciuria. Because a lot of calcium is there in the urine, the blood, calcium will be reduced. So there will be hypocalcemia, hypercalciuria, and low urine citrate. So just look at all these together: hypercalciuria, low urine citrate, alkaline urine. All these three factors tend to predispose to stone formation. Stone formation, nephrolithiasis, nephrocalcinosis. Nephrocalcinosis is nothing but stone in the substance of the kidney, and renal stone nephrolithiasis is stone in the different collecting areas of the kidney. And there tends to be bone demineralization as well. So here you can see an X-ray showing nephrocalcinosis. All these radio opaque areas you can see here are stones. Mostly they are calcium phosphate stones. So hypercalciuria, low urine citrate, and alkaline urine pH contribute to renal stone formation. So why do you see alkaline urine pH? Just as I told before, H plus is not being secreted into your lumen. So H plus is basically acid. If H plus is not being secreted into the lumen of the distal convoluted tubule, so what do you think is going to happen? There is going to be less of acid. So less of acid means the urine is going to be alkaline. In other words, the pH is going to be more than 5.3, and this predisposes to stone formation. And now coming to the causes. The different causes could be autoimmune conditions like lupus, rheumatoid arthritis, Sjogren's syndrome. Drugs like amphotericin B and lithium can also contribute. In fact, whenever a patient is started on amphotericin B or lithium, we always check the serum potassium levels, the reason for that being type 1 RTA. And multiple myeloma light chains can also deposit and damage these and alpha intercalated cells, and lead to type 1 RTA. Sickle cell trait and disease and chronic urinary tract obstruction and liver cirrhosis are some of the other conditions that you need to associate with type 1 RTA. I hope it is clear for you. The things that happen are hypokalemia, hyperchloremia, hypercalciuria, hypocalcemia, low urine citrate, and renal stone formation. And the acidosis here tends to be very severe, and the potassium loss also tends to be very severe. And that's about it about type 1 RTA. And you can see the associated conditions are, as I told before, lupus, autoimmune conditions, sometimes amphotericin lithium, myeloma light chain, sickle cell trait disease, chronic urinary tract obstruction, and liver cirrhosis. The other one now we'll talk about proximal renal tubular acidosis, type 2 RTA. So what happens here is the main defect here is in the PCT. In type 1 RTA, the defect is in the DCT, whereas in type 2 RTA, the defect is in the PCT, proximal convoluted tubule. Here there is basically a problem in reabsorption of bicarbonate in the proximal convoluted tubule. The alpha intercalated cells of DCT are normal. So, as I told before, the main mechanism for renal acid handling is through H plus secretion in the distal convoluted tubule. And since this mechanism is normal, the acidemia here you see in proximal RTA will be less severe. Consequently, the hypokalemia you see will also be less severe. And the urine pH tends to be less than 5.3. Why is it less than 5.3? There is H plus secretion. H plus secretion in DCT is intact. Because H plus secretion in DCT is intact, and because this is the main mechanism by which renal acid handling is done, urine pH is less than 5.3. So the urine pH is not alkaline, so there is no tendency for stone formation. And the different causes for type 2 RTA could be Fanconi syndrome. Fanconi syndrome is nothing but a condition in which there is glycosuria, phosphaturia, uricosuria, aminoaciduria. So all these substances are lost in the urine in Fanconi syndrome. And another inherited defect called cystinosis that can also damage the PCT and lead to type 2 RTA. Heavy metals like lead, arsenic, drugs tenofovir, which is used in the treatment of HIV, hepatitis B, tenofovir can cause type 2 RTA, ifosfamide chemotherapeutic agent, and carbonic anhydrase inhibitors. So all these agents can cause type 2 RTA or proximal RTA. Here also you can see hypokalemia. Type 1 RTA also had hypokalemia, and this one also has hypokalemia. The thing is, hypokalemia is less severe in type 2 RTA, but hypokalemia nonetheless is there, and the defect is in the PCT here. And we saw certain conditions, causes, drugs which are associated with type 2 RTA. Now let's go to type 4 RTA. Type 4 RTA is the most common RTA in adults. Type 4 RTA basically can be due to hypoaldosteronism. The hypoaldosteronism can be primary or hyporeninemic hypoaldosteronism or aldosterone resistance. So what is the action of aldosterone? Aldosterone is responsible for sodium and water reabsorption and potassium excretion. So when there is hypoaldosteronism, potassium cannot be excreted, so potassium level increases. This causes hyperkalemia. So the only renal tubular acidosis which is associated with hyperkalemia is type 4 RTA. Okay, there is another entity called hyporeninemic hypoaldosteronism. What is this? This most commonly occurs in diabetes. Diabetes, there is hyaline arteriolosclerosis of these. Can you see the afferent arteriole here? There is hyaline arteriolosclerosis of the afferent arteriole, and this leads to a kind of damage occurring in the juxtaglomerular apparatus. So because of the damage in juxtaglomerular apparatus, the renin secretion is decreased. So renin stimulates secretion of angiotensin. Angiotensin stimulates secretion of aldosterone. So if renin levels are low, consequently the aldosterone levels will also go low. So this is a type of aldosteronism called hyporeninemic hypoaldosteronism. This occurs in diabetes, and this can also occur in conditions like Legionnaires' disease, where there is acute or chronic tubulointerstitial inflammation. So when there is tubulointerstitial inflammation, that can also damage this juxtaglomerular apparatus. The juxtaglomerular apparatus basically consists of a portion of the afferent arteriole and the myocytes surrounding the afferent arteriole, and the extraglomerular mesangium, granular cells, and the macula densa cells of the distal convoluted tubule. So all these together form the juxtaglomerular apparatus. So it can be affected by arterial damage due to hyaline arteriolosclerosis of afferent arteriole, which occurs in diabetes, and acute or chronic tubular interstitial inflammation, which occurs in conditions like Degenerative disease. And there could be some other drugs which are associated with type 4 RTA, and they include NSAIDs, beta blockers, CNIs, cyclosporin, and ACE inhibitors, ARBs, potassium sparing diuretics like spironolactone, eplerenone, and drugs like trimethoprim and pentamidine, which can be used in treatment of pneumocystis, pneumonia, and other things. So these are the different causes of type 4 RTA. So the important thing that you need to remember as far as type 4 RTA is concerned is the hyperkalemia. Hyperkalemia is associated only with type 4 RTA. Type 1 and type 2 RTA have hypokalemia, which is associated. So the treatment aspect also in type 4 RTA focuses on treating the hyperkalemia. So once you get rid of hyperkalemia, the type 4 RTA could also be corrected. And another thing that I would like to mention is hyperkalemia decreases ammoniogenesis in the proximal convoluted tubule. So what happens is there is ammonia formation in the proximal convoluted tubule, and ammonia, is it a good substance or a bad substance? I know you'll be telling me that it is a bad substance. So ammonia, which is formed, combines with H plus to form ammonium. So this ammonium goes out into the lumen of the nephron. Going into the lumen of the nephron because it has to be excreted. So to maintain electrical neutrality, ammonium is going out and sodium is coming in. Okay, and this ammonium which goes out into the lumen of the nephron combines with chlorine to form ammonium chloride. Okay, and some ammonia it goes out as ammonium chloride, and some of this ammonia is reabsorbed by the thick ascending limb of the loop of Henle, and it goes into the medullary interstitial fluid. From the medullary interstitial fluid, this ammonia goes back into the lumen of the nephron. So ammonium is a base. Ammonium, all these are bases. So what is the use of base? A base is used to buffer acid. So this ammonia, which is in the medullary interstitial fluid, once again it gets transported into the lumen of the nephron to neutralize the acidity. So this is known as titratable acidity. Okay, so basically ammonia plays a role in titratable acidity. This is what you need to remember. And hyperkalemia inhibits ammoniogenesis. So when you cannot titrate the acid in the lumen of the nephron, what's going to happen? There is going to be acid buildup in the lumen of the nephron. So when there is acid buildup in the lumen of the nephron, there tends to be a back leak into the blood. For example, this is the lumen of the nephron, and there is this ammonia is not being secreted here because of the defect in ammoniogenesis. So there is going to be, but the alpha intercalated cells put out a lot of H plus here. So the acidity in the luminal side of the nephron is going to increase. So when ammonia is not there to neutralize the acidity, H plus is going to build up here. And as H plus builds up here, there is going to be back leak into the blood. So this is the blood side, and that is the luminal side. So H plus is going to back leak into the blood. When there is H plus leaking into the blood, what do you call that? Acidosis. So that is the reason why type 4 RTA is classified under acidosis. Okay, there will be hyperkalemia, and because of hyperkalemia, there will be problem with renal ammonia generation. And because ammonia is not being generated, it cannot be used to titrate the acidity, and because of that, there will be H plus buildup, and this H plus tends to back leak into the blood, and this causes acidosis. So now coming to the treatment. Now we've seen the causes for the different three types of acidosis, the features that you get, the symptoms that you can get, the renal stone formation, and the urine pH, and all those things. We've seen in detail about all those things. Now let's go straight into the treatment. So bicarbonate replacement is the cornerstone of treatment of renal tubular acidosis. So the main pathology, as I told before in the first slide, is bicarbonate loss. Okay, so we can replace bicarbonate, you can correct the metabolic acid, you can correct RTA. And for type 1 RTA, you replace bicarbonate, of course, and you correct the hypokalemia. As I told before, the degree of acute hypokalemia can be severe, so you need to correct it more aggressively. And you can give potassium citrate to treat the stones. So why do you give potassium citrate? I just told that there will be low urine citrate. Low urine citrate, hypercalciuria, and alkaline urine. So to treat all that, you can give potassium citrate, okay, to treat the stones. And you should always look for the underlying cause. It could be any autoimmune condition, or it could be any multiple myeloma or drugs. You look for the underlying cause. So for type 2 RTA also, the treatment cornerstone of treatment is bicarbonate replacement and correction of hypokalemia if present. And for type 4 RTA, as I told before in the previous slide, the main step is to correct the underlying hyperkalemia. So it is hyperkalemia here, which is the main problem, which is impairing ammonia generation in the proximal tubule and also causing all the features associated with type 4 RTA. So for that, what you do dietary restriction of potassium, loop diuretics to get rid of the potassium, and fludrocortisone. Fludrocortisone is a mineralocorticoid. You give that in patients with hypoaldosteronism. As I told before, type 4 RTA can be because of hypoaldosteronism or aldosterone resistance. Aldosterone resistance. Aldosterone resistance is also called pseudohypoaldosteronism. Pseudohypoaldosteronism. Aldosterone resistance means that there is a problem with the receptors. Aldosterone levels will be normal or regulated, but problem with the receptor. Problem with receptors. Okay. So type 4 RTA can be because of primary hypoaldosteronism or aldosterone resistance. And also diabetes. Diabetes causes a special type of hypoaldosteronism called hyporeninemic hypoaldosteronism due to damage of the juxtaglomerular apparatus. And in this case, you just treat the underlying hyperkalemia with loop diuretics, do dietary restriction, and if the patient is aldosterone deficient, you give them fludrocortisone, and you look for other drug-induced causes. So this is in detail about the different types of RTA. So that is about the treatment of renal tubular acidosis of the different types of RTA. So that brings us to the end of this video. And I would also like to tell you that if you like my way of teaching, please be sure to check out my course on chest X-rays. I've given the link in the description. It is a 1 hour long course, on chest X-ray interpretation. The name of the course is How to Read Chest X-ray Like an Expert. So please be sure to check out that course and also subscribe to this channel for more such videos and informative content. I'll see you in another video. Thank you very much for watching.